Hello, everyone. My name is Carolyn Toohey, and I'm very pleased to welcome you to this sixth in our series of virtual panels in the Monk School Queen's International Institute of Social Policy for 2022. To begin, I would like to acknowledge that the University of Toronto is situated on the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River, while Queen's University is situated on traditional Anishinaabe territory and Haudenosaunee territory. Today, these meeting places are still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to live and learn on this land. As we enter into our discussion today, may I ask you also to reflect on the land on which you yourselves are situated. For over 25 years, the International Institute on Social Policy has brought together researchers, policymakers, community leaders, and service providers to discuss the most pressing social policy challenges facing Canada and other OECD nations. This year, Queen's University and the Monk School of Global Affairs and Public Policy have joined forces to host an ambitious program focused on whether and how we need to reform or even transform Canadian social policy for a more resilient and successful future. The 2020 Institute launched on October 31st at a day-long conference at the Monk School on the overall challenges and policy choices facing Canada and other OECD countries, socioeconomic, cultural, generational, and political. Today's session is on health systems, the largest area of social policy in terms of fiscal footprint, and one which consistently ranks at the top of public concerns as a priority for government action. As I said, this is the sixth in a series of 9 virtual policy seminars drilling down into major areas of social policy. The earlier seminars are available for viewing on the Monk School of Global Affairs and Public Policy YouTube channel, linked through our website, and each new seminar will be posted as it is completed. Today, I'm thrilled that we have 3 of the most knowledgeable observers of health systems in Canada and internationally who bring not only that knowledge, but also their active engagement in the policy process to the table with us today. First, I would like to introduce our moderator for this session, who will then take over and introduce our 2 distinguished speakers and manage the discussion. Chris Simpson is currently Executive Vice President Medical and Chief Medical Officer at Ontario Health, where he has helped to lead the health system response to the COVID-19 pandemic. He's an eminent cardiologist with an academic appointment at Queen's University and a research affiliation with the Institute for Clinical Evaluative Sciences. He has held senior and central positions in the health policy space, including president of the Canadian Medical Association in 2014-2015, vice dean of the Queen's Faculty of Health Sciences from 2016 to 2021, and president of the Canadian Academy of Health Sciences in 2020-2021. Perhaps the most intriguing part of his history, however, is the fact that in his undergraduate days at the University of New Brunswick, he was a professional saxophonist with a well-known 21-piece big swing band, the Thomas, and seriously considered a professional career as a musician. The music world's loss is most decidedly medicine's gain in many dimensions. Chris, thanks so much for leading the seminar today. Over to you now.
Well, thanks so much, Carolyn, and welcome everybody. It's really a pleasure to be here, and I'm really looking forward to this discussion today. Just a reminder on the housekeeping side of things that we'll be hearing from both of our speakers consecutively. They'll each be speaking for 20 to 25 minutes, and then we'll be going to a discussion. We would invite your questions and comments in the Q&A. You'll find the tab at the bottom of the screen, and you can enter your question there. I'll receive them and try to get to them as best we can. we'll certainly be wrapping them up into themes very, very likely. So we'll look forward to your active participation. So it gives me great pleasure to introduce our two distinguished speakers. Joseph Figueras is Director and co-founder of the European Observatory on Health Systems and Policies. In addition to his work at World Health Organization, he has served major multilateral agencies such as the European Commission of the World Bank, and has worked as policy advisor in more than 40 countries within the European region and beyond. He is co-chair of the Scientific Advisory Board of the Monti Commission and is a member of several governing, advisory, and editorial boards, including the governance board of the European Health Forum Gastein. He's an honorary fellow of the UK Faculty of Public Health, has received the Andrea Stampar Medal for Excellence in Public Health, and is the recipient of a doctorate honoris causa from Semmelweis University. He has 3 times been awarded the EHMA Prize for Best Annual Publication. He's currently visiting professor at the London School of Economics and external examiner at London Maastricht University. He was director of the Master of Science in Health Services Management and lecturer at the London School of Hygiene and Tropical Medicine. And he started his career as a specialist in family and community medicine in Spain. His research focuses on comparative health system and policy analysis, and he's editor of several publications in the field, including the European Observatory series published by Open University Press, and since 2019 by Cambridge University Press. And Sarah Allen is an associate professor of health policy at the Institute of Health Policy, Management and Evaluation, Dalla Lana School of Public Health at the University of Toronto. She's also director of the North American Observatory on Health Systems and Policies, NAO, a collaborative partnership and research center focused on subnational and international health systems research to support evidence-informed policymaking. Dr. Allen's research and teaching span comparative health systems and policies, health system performance, and health equity. So without further ado, Josep, I'm going to turn things over to you, and we'll then have a brief pause and over to Sarah when you're complete your presentation.
Thanks. Thanks very much, Chris. Thanks very much, Caroline. What a pleasure to be here today with you. What I wanted to do in these first few minutes of my presentation is to reflect on the implementation and transformation of health systems, a key challenge that we all face in this region as well as at the other side of the big pond. And without wanting to talk about COVID, because that's not the focus of my presentation, I think there are many lessons that we can draw from COVID in actually building back better, in actually facing the new priorities and implementing change. The first perhaps concept that I like to make reference to is that concept of resilience. Before actually the crisis, we already did some publications on the area of strengthening health systems resilience, and we began to incorporate that work into the assessment of health systems in our region. And the concept of resilience is, of course, key now, not only for COVID, but any other inevitable future shocks, be it the environment, be it war, I hope not, be it financial crisis, or in this part of the world, the issues around a refugees crisis. So we define resilience as the ability to prepare for, manage, absorb, adapt, and transform, and learn from shocks. So we want to go beyond COVID and start thinking, what are the kinds of shocks that our health systems are going to be facing? Just to give you a sense of the kinds of publications we've been doing on the subject of implementation of priorities, drawing from COVID, but also with from other health system reforms. And thanking Sarah here because of the excellent collaboration we have with the North American Observatory, which in many ways, for our purposes, is very much part of the European region. There are lots of interesting comparisons and interesting learnings and cross-country lessons between Canada and our member states in this part of the world. So these are the kinds of strategies that we put together, we draw from this research, 20 strategies. It looks too much of a shopping list. Don't worry, I'm not going to submit you to all of those. It rather serves me for the kinds of reflections, as I said, about the kinds of priorities we're looking towards now in Building Back Better and the kinds of lessons for implementation. And a bit the thesis I'm pursuing today is in this square, in this text box. COVID uncovered known health systems vulnerabilities. I will argue as much as necessary that a lot of what we learned from COVID, we knew already. So we didn't learn it. It just was the trigger that showed us the vulnerabilities, be it in delivery, be it in our health workforce, and be it, importantly, I'll be talking a lot about that, in governance, and reflects in many ways past failures on implementation of needed reforms. So based on that, how do we implement and harness a lot of the innovation we saw during COVID? In many ways, if there is a silver cloud in COVID, it has been the ability to introduce change at a fast pace. What were the elements of the success in implementing change? Are there any ways to replicate those in future, or do we need another shock? We need another COVID, we need another virus? I hope not. So what are the kinds of lessons from COVID? Lessons that, as I said, were there anyway. I'm going to use COVID as an excuse, but I'm going to expand. And the question is, do we have now additional political, financial, or managerial capital to implement needed change? Do we have now in a position, in a window of opportunity? From implementation, as Donald Trump realized, is rather complex. Nobody knew he realized healthcare could be so complicated. And a lot of that complication stays in this area, on the governance. Governance is essential to an effective implementation. These are the 9 strategies we draw from our research, as I said, with the North American Observatory and the European Observatory, that in terms of Europe, it takes the European Union as well as the rest of the European continent. Incidentally, my perspective to all that is as director of the Observatory, which is a partnership with 12 member states, the European Commission and WHO, whose role is actually support member states with evidence for policy implementation. So these 9, again, a long shopping list. I'd like to make some comments, talk a little bit more perhaps about a subset of those that could be particularly relevant in the case of Canada, but in many other countries as well. So let me draw and make a slide sort of highlights each one of these areas. I'm very much aware, of course, that these are highlights, and each one of those would take probably a whole seminar to debate and to learn in detail. But what I hope today is 2 things. One, that you'll be enticed to look at the kind of research that we developed together with the North American Observatory, and entice you as well to, during the discussion, to explore some of those in more detail, those areas that you're more interested. Political leadership is obviously, this is a nonsense even saying it, is fundamental for change. Not only the leadership, but the communication. Just the faces of these key decision makers gives you a sense of the complexities we have at the technical level and the lower policy making level to implement change under certain government and leaders that we can do little about because are the results of our democratic systems. But there are many lessons there. And there are lessons actually in this case. I thought, I'm sure you're all thinking I was going to be very critical about these individuals. Actually, I'm not going to be critical. I'm going to be the opposite. Having worked, not with prime ministers, but certainly with many, if not most, ministers of health in the region, we need to be very humble from the evidence and civil service perspective supporting them. First of all, because we sometimes fail to understand, and that may be very obvious, but I still see researchers and advisors forgetting that. They need to respond to particular political and cultural values and contexts, not only with COVID, with many of the reforms. And that's something we do not understand. I say to my staff when we support member states that policymakers take decisions not based on evidence, but informed by evidence. So my aim when I work with member states is that policymakers are informed by the evidence, but I understand the need for them to make trade-offs. I mean, I put here some examples that were very clear during the COVID pandemic. So the Dutch autonomy and liberal values in the sense that didn't want to introduce masks, for instance, the British aversion to nanism, or the Swedish exceptionalism and the concept of the opinion corridor. I don't want to get in detail, but those were the key elements that actually shaped the decisions, well beyond the evidence on the use of masks, on the use of preventive activities. And also being supportive to these policymakers, they have to make decisions under an enormous amount of uncertainty. So one thing that we learn is, yes, you make trade-offs and you make them transparently. And secondly, when you look at effectiveness in the management of change, is your ability to communicate uncertainty and do it with humility, because that really creates trust and compliance. And some of the examples on the figures you saw here, such as Madame Merkel or Jacinta Ardern, are good examples of good communication, as well as your Prime Minister, by the way, as I understand it from this perspective, from my own outsider perspective. By the way, we published some work about arguing that women are much better, women prime ministers, presidents are much better than men in actually communicating uncertainty effectively. I'll leave it up to you to judge. So leadership and communication in any reform will be fundamental. The second element today is how we back that decision-making with effective transference and translation. This evidence to policy. We're pretty bad in some instances in doing that transference of evidence. And when we do that, and that we learn a lot during the crisis, is being, look at these t-shirts. To me, that these t-shirts fascinates me. These are individuals, actually, I know the three of them, who are the czars of presenting evidence and communicating during the COVID crisis. Actually, I had a meeting with them in closed doors about the complexities in communication during that period. And you have different styles, you have different approaches, but one thing they all told me is the multidisciplinarity, the need to understand the values, the cultures, the sociology, as well as the epidemiology. In how many instances we've seen epidemiologists taking the lead, or microbiologists, and getting the social sort of media, the social platforms to advise and counteract or contradict government advice, sometimes based in very narrow views. So there's a lot of narrow scientific views, scientific in terms of microbiology or epidemiology. So let's remember one key area is the transfer of evidence to policy. It's not only for COVID, for many reforms. And importantly, and we're pretty lousy in the public sector in doing that, in understanding the infodemics. Tedros, our Director General of WHO, talked about fake news spreads faster and more easily than a virus and can be just as dangerous. What I'm suggesting here today is, do we have in place the kinds of mechanisms to monitor the views of interest groups? Do we understand what they're thinking? Are we counteracting that when we want to sell a reform with the actual messages? Either be social sort of commercial determinants of health, trying to steer the debate on health in different directions, either be genuine views of the medical profession, but are we then prepared to ask policymakers to respond to those? Do we understand what's going on? Third, and it all sounds straightforward, but we don't do it in practice. The involvement of stakeholders and civil society. We've been looking at many countries, and those countries that have engaged with the medical profession, with the health profession in general, and broad civil society, were key in implementing reform during COVID and others. This commitment, this accountability, and this trust. I will argue today it's not only about the professions, but the civil society. We're not using effectively civil society for the implementation of reform. And it can be used in actually quite Machiavellic ways. I shared notes with some civil servants in governments that when they see their political master not quite moving, I shouldn't be saying that perhaps, but I won't tell you which countries, they leak the kinds of evidence to civil society to get the kind of pressure that is needed to implement change. So acceptability, support on communication. Again, we learn a lot. There are examples here that I don't have time to present of how well that worked during COVID, but I could present example after example of the key role of civil society and the stakeholders, of course, in the implementation of reform. An area that I know is very close to your heart in Canada, and certainly the country where I come from, Spain, as well as many of the Nordic countries. One of the areas that was fascinating us, is the degree of decentralization or centralization during the reforms, during COVID, and whether that made a difference or not. And in that, I'm talking not only vertically, like the provinces in Canada, but horizontally. It's been fascinating to see how some member states was the Institute of Public Health leading the response. In some member states was the Prime Minister. In some member states, the Ministry of Health. In some member states was actually the military with the Ministry of Health making the decisions. And what are the differences between those? Well, I suppose I'm going to disappoint you a tiny bit, but there were no differences. What really made the difference is ability to align priorities and really agree with each other. The ability not to politicize response and not to COVID, to reforms. Come from a country where that happens all the time. The transparency and accountability to those who make the decisions. And indeed, an area that finally, not finally, because we've been proving that for a long time, you guys in Canada have been very much proponents on health in all policies. We've seen the importance in the COVID response. It's been the key example of working across sectors. In reality, the resilience of systems have been as much because of the health, but because of the social systems as well, and the economic systems. The ability to respond with labor protection during the crisis in cases of possible, if you are infected of COVID, and the need for you to separate yourselves to follow quarantine would depend very much on whether there were social benefits, whether there are labor laws that would protect these people to actually be able to isolate themselves. Because with many people with precarious employment, there was no incentive whatsoever to isolate themselves if they felt they had COVID. Another interesting area that fascinates me, fascinates all of us now, is what's coming now. There are two bands. Some people say, yes, we can prove that we should invest on health systems. So one of the key areas in terms of implementing change is bringing more resources, more support to the health systems. So can we make now a stronger case for investing in health systems in the face of some, say, budget cuts? In some countries, we're seeing that the resources go to the military, by the way, because of the Ukrainian crisis, or go to the environment, which again has a huge impact on health as well. So what do we think about that? Perhaps something we can discuss later, Chris. Two elements I want to highlight here very quickly. We can now show that health is not only good for well-being, but is key to security, sustainability, and growth, as well as well-being. And there's a whole movement now, we can talk about that later, about the economy of well-being, saying the GDP may not be the best way to reflect economic growth, to reflect well-being, I meant. And we need to find other measures in which health is key and very important. I leave it there. UHC, universal health coverage, is not something desirable because of equity. It's important because it has shown that has helped us to have effective responses to shocks. We saw that during the financial crisis, 2008, we did lots of research on that. We saw in this continent during our refugee crisis, and we've seen it during COVID. The ability to have UHC, to have access, made a huge difference on the effectiveness to the response. But of course, as you see in this brief we presented in a ministerial conference a while ago, we need to go back to Minister of Finance and say this is not a black hole, as they like to say, but actually we need to demonstrate value for money, and we need to put in place how the funds go to invest on those right areas. The second element in this slide is not only health in all policies, what education can do for me, environment can do for me, the co-benefits from others to health, but perhaps a moment, something we are pursuing and championing in the observatory is health for all policies. Actually, health is good for the environment. Our hospitals account for 8%, 10% of the actual carbon footprint. Perhaps a more sustainable diet, which would be healthier, would be decreasing the amount of beef, which is, again, very important for the environment. We are good for education. We are good for poverty. We are good for economic growth, for gender equality. So perhaps these are elements that we in the health sector, we can put forward to the Minister of Finance and other sectors, not just finance, to make a case for more investment in our field. Another lesson, and I'll stop here in terms of governance, is this idea of global health governance. We've seen that in the European Union, where subsidiarity was key, you know, subsidiary member states make decisions on health systems, but we all realize that there's this thing about public health goods, public global goods. And if there is no global health governance beyond the virus, by the way, beyond the virus, because there are many other shocks that cross borders, is a must for security, sustainability, as well as, of course, solidarity. This is the Monti Commission of the two main ones. They've been there. I was fortunate to be in the Secretariat. There's the Helen Clark Commission as well that looked at, reviewed at the response to COVID. This is made for former prime ministers, bankers, and others. And as you would imagine, like many other commissions, went very much into the concept of One Health, but actually talked a lot about a reformed global financial system and this idea of global public goods. So there is this realization of, as I said, of global public health goods. Governments have realized that they must pull some degree of sovereignty. And we have to go beyond COVID. As I said, not only viruses cross borders. So now we have been studying, and if you want, we can talk about that, about a plethora of international governance approaches, collaborations such as the pandemic treaty, such as the initiatives on One Health, or the G20. We put forward to the G20 a health fund very similar to the one that is used for the environment, to try to support the One Health and support these kinds of initiatives that are as important as the environment in many ways to ensure this sustainability and solidarity. One other area, I'm getting there within the time, I believe, that if there is one area we need to prioritize, of all these 20 shopping lists I gave you, is the health workforce. Clearly, we knew that, we've been knowing that for a long time, but the COVID crisis has put our workforce at the very limit of their resilience, basically. These two slides show something that you're familiar with. On the right is Europe, the European Union, showing the differences in the distribution of doctors, not only between the countries, but also within the countries. Actually, some of the main problems are the distribution within the countries. Actually, what we see in Europe is that some of the problems in Romania are caused by the problems in France, by attracting the French, attracting the Romanian doctors, because similarities in language. But what I'm interested for you to see is on the left-hand side. This is a very interesting slide that we developed that way to present the data with the observatory and the OECD, where on the vertical puts practicing nurses and the horizontal practicing doctors. You see the huge difference in a skill mix. What does that tell us? Well, it tells us that the lower left quadrant, they're in deep trouble because they have neither lots of doctors or lots of nurses, very low in both areas. So we need to, like Poland. But it tells you the huge variation in the skill mix. And that's one area that we need to be pursuing much more proactively as a way to deal with the shortages, as well as the way to be more efficient and have better quality. By the way, I put among all the European Union countries, Canada, which would seem to be mostly high in nurses and relatively low in doctors. Take that with a pinch of salt, doesn't say much, but it says there's variation, and we need to think of this variation. Bottom line, we have a demotivated health workforce. They've been tested and strained to the limit. PTSDs in Italy, 49%, 57% in Spain, and 46% in Austria of our health professionals. These are based on some surveys. And a reminder that the aging of our health workforce, around 1/3 of doctors are over 55 on the overall OECD. I think Canada is around 33%, but there are countries in the OECD like Italy that's around 60%, which is extremely concerning. So again, long lists. I don't want to bother you or bore you with so much. I just want to entice you to see the amount of new strategies we need to be working on in the health workforce and remind you of prioritizing those massively. What I'm saying here is we need to scale, existing capacity. We need to attract the youth to the health professions. We need better redeployment strategies, better incentives. There's a lot of research on that. The reskilling and repurposing, I was already talking about that. I'll say a tiny bit more in a minute. And also supporting and protecting the mental health and the working conditions. And some of that doesn't need, it's not just financial compensation. Sometimes it's about the nursing or the doctor staff having nurseries in the hospitals. Sometimes it's flexibility in their working hours. So some of that is just paying a tiny bit of attention, and it's not that expensive and can make a huge difference in retention. This is some of the work we've been doing. Again, I would love to have a whole day to talk about that. We are very excited about implementing skill mix innovations. Let me give you an example. Many years ago, you can see by my age, although I'm not that old, I used to be a GP, and the nurses I'm working with, they were prescribing. They were prescribing. 30-something years later, there still is not legal for the nurses to prescribe in my own country. What is the difference? Is it evidence? Do we need more evidence about the role of nurses, pharmacists, physician assistants, medical assistants, or patient navigators? Or is it because we are very lousy at areas of regulation, training, incentives, and so on, and culture of the professions? You have here some examples about care coordination, different teams between doctors and nurses or social workers. There's a lot of rich evidence there about schemes that are cost-effective in their work, but the idea is how to implement them. Let me highlight this research, which is around integrated care, and how we looked at different approaches in different countries, showing different skills, mix, innovations that were key in making change, in implementing change, and particularly focusing, as I said, on regulatory changes, focusing on incentives and so on. How often we introduce incentives in the health system and we forget those who are non-doctors. We forget them entirely, and yet we're talking about a primary care team. Finally, I would have liked to have more time, but I really want to have these questions, and I'm 3-4 minutes within my 25 minutes. I would like to talk so much about implementing innovation. How many innovations have been implemented so quickly, so fast, and so effectively during COVID? Innovations that were, as I would say, in the first drawer of the Minister of Health. They were there ready to go. And we had that window of opportunity. Do we need to have those window of opportunities to implement these innovations? I saw introducing new payment systems, for instance, for digital health, within 2 weeks. We were working with France and the Netherlands on that. I saw effective decentralized management. Some people would say because the top level could not handle the hospitals because of the chaos of COVID. Actually, the hospitals themselves are starting managing themselves with enormous good results. New patient care pathways, introduction of guidelines, fast track. Primary care has shown during the crisis what we knew for many years. It is cost effective. And make no mistakes, the Germans like to say, we did the crisis well because of the hospitals. No, that's not true. They have lots of beds, and that may be good or bad. That's another question. A colleague of mine who's been arguing with them they should have less beds has been now criticized because of COVID. What I'm saying here is the key effectiveness of COVID responses wasn't the number of hospitals, was the ability of primary health care to monitor, to control, to deal with the cases in the community before they were admitted. And I'm getting there, Chris, just talking about digital health and making this point again and again and again. Look at this slide. This slide is share of population that had a remote GP consultation. I'm sorry, I don't have this data from Canada, and I looked for it, but this is data we only have for the European Union. Which countries are there at the lower level of using remote GP consultation? Bulgaria is there, a poor country, but France and Germany are there. Why? Because it's a culture of doctors, because of the incentives, because of the mistrust with the system, because of the worries of being controlled. So we've been looking at the introduction of digital health tools. We had the whole summer school on the subject. And what I'm saying today is for implementation is not only investing massively in this area, which is with new technologies and so on, but also Are we training our staff to use that appropriately? Do we have the legal frameworks to protect them in case things don't go well? Do we have the quality measurements? Do we have the guidelines in place? This is where we need to invest as much as in the actual capacity and technology. Let me give you, to finish, this example. This is Portugal. Since 2013, one particular example, hospital dermatological consultations. This is the simplest technology. This is my telephone. You make a picture of a lesion, you send it to a dermatologist, the hospital, as a GP, and can screen in a large number of cases whether this needs to be seen in the hospital. Look, the introduced in 2013, nothing happened. As you can see, is the levels of a referral with telescreening and without telescreening. What happened in 2019, apart from COVID, or 2018 rather? Well, they said to the hospitals, if there is less than 80%, if there is no more than 80% of the referrals that have seen by teledermatology, we won't reimburse you. And of course, they made sure that the dermatologist in the hospital had an incentive to do that. Look at the change. It's not the technology stupid, as I would say. It's these other elements that are important. I made the point ad nauseam, governance. I think global governance is fundamental. I think we can make a case of investing on health systems more effectively. Public health, primary health care, definitely workforce, and the implementation of digital. A lot of work on the health works, as I said. There's plenty of innovation in service delivery, which has been there, which we have the evidence, but we haven't put the kinds of incentives, regulation, as I said, and now some training and culture to put them in place. And the scaling of digital health is a very good example. And finally, what I'm calling for, and we're doing a lot of research of that, is innovating in the implementation of innovation. We should do research on implementation. And I'm very happy now there began to be some programs on doing research on implementation of innovation rather than innovation as such. Thanks very much.
Well, thanks so much, Joseph. What a great way to kick things off. I've got 4 pages of notes here and I can hardly wait to have a conversation with you, but let's move on to Sarah next, and we'll hear her presentation. And I expect that there may be some interesting intersections. So Sarah, over to you.
Thanks so much. And I agree, that was a wonderful presentation and I'm really honored to be on this panel today. And I'll just jump into it with a brief outline. I'm going to talk a little bit about the Canadian context and, talk about some key indicators of spending, resources, and performance. And then I'll provide my sort of top challenges that we're facing, as well as top priorities for reform. And then I look forward to time in the discussion. But first, before I get into context, I just want to say a little bit about what this North American Observatory is, and some of our work that's been really fundamental in sort of facilitating comparative research. And the name sounds a lot like the European Observatory, and that's no accident. We're very much inspired by and a sister organization to the European Observatory, but with more of a focus on the decentralized health systems in North America. And these are the book series that we co-produced with the European Observatory on each country's health systems. And these book-length studies of health systems, we've replicated also in Canada and are producing these for each province. And while the books in themselves don't provide the particular, the data and analysis within each topic area that I'm going to talk about today, they really do provide the foundation, the in-depth knowledge that we need to understand the history of each system, the particular context, the social and cultural variations that we see that really Joseph spoke to really well in terms of why some reforms might be more difficult to implement than others. So onto data. Now that we've had a huge surge in spending, Canada is among the top spenders in the world. And this is the most recent data coming out of MQIISP in its National Health Expenditures database. And, Canada moves around a little bit depending on which metric we use, but we know that we're a top spender and have been in the top 10 for many years. And, so we have a lot of resources going into healthcare, and yet we have many, many challenges. And one of them is around healthcare capacity. So I'm providing similar data to what Joseph shared in terms of, our level of spending is high. The number of beds we have is quite low. The supply of doctors, just counting people, not full-time equivalents or how much they're practicing, but the number is low relative to OECD countries on average. And nurses is slightly above the average, but more in the middle of the spectrum here. And this nice interactive tool is available on the OECD website. And this was from 2021, and it hasn't changed much in recent, more recent data output. So we have lower capacity than our peers. And we also have on many indicators, poor performance. This is just one way of sort of getting a snapshot based on the surveys and data sets compiled by the Commonwealth Fund that look to high-income countries on about 72 different measures and aggregate those and to try and group the countries in terms of overall performance. And Canada is at the bottom of the pack. Obviously, the United States is in its own category altogether. However, it's consistent. Again, every 3 years, the Commonwealth Fund produces this report. And every time Canada is next to the bottom on overall performance, and it's driven by some indicators more than others, but it's a consistent finding and again, motivator for the types of changes that we need. And then COVID came. Obviously, the shocks to the health systems have been enormous. While there's been some rapid innovation and change, as Joseph spoke to, there's also been huge increase in deaths, excess deaths, also those related to COVID. However, in comparison with some of our peer countries, Canada has done fairly well in terms of being a slightly better performer on some of these indicators, in terms of having mitigated some of what could have been even worse in terms of the outcomes to people. Also having higher vaccination rates, and this is slightly older data, so these numbers have changed slightly, but the overall picture is the same, that we've done fairly well in spite of all the challenges that we face. And perhaps we could have done much better if we had addressed some of these long-standing issues. And I'll just put a quick flag to the European Observatory's group that Canada's been a member of, this Health Systems and Policy Monitor, which has enabled really rich and rapid comparative research across many countries. And it's been a real honor and privilege to be part of this mostly European group, but Canada and the United States have been able to participate, which is really helpful in terms of learning about some of the shared challenges and how different countries are addressing them. And we were contributing also to COVID policy responses and being able to compare these within a common standardized template. And then that work has, we worked on that for at least a year during the pandemic and perhaps longer. So there's a huge database there for people to look at and compare Canada to the European countries. However, moving on to other aspects of the health system and our performance, we often lack information on, the views of people themselves in terms of how their experiences are in the health system and what are their concerns and challenges and perceptions. And so one of the data sets that we do have now, thanks to MQIISP standard surveys, is from inpatients. So hospital inpatient experience is one of the few comparable data sets that we have where we're asking people how their experience was after they're discharged from the hospital. And the data are a range of dates, and there's only 5 provinces contributing so far. And the 3 of the provinces, the data reported here were during the pandemic, and in the 2 Atlantic provinces, they were before the pandemic. So I'm not sure how comparable they are, but overall, there's a huge room for improvement in terms of overall inpatient experience. And then when we look at whether individuals are reporting that their friends and family are involved in decisions, it's even poorer in terms of the experiences of people. So we know that there's major improvements that could be made here. One of the persistent problems with health systems in Canada is with access to care, and access to primary care is one aspect that is particularly challenging. And not only are there, depending on the province, between 10 and 20% of Canadians without a regular primary care provider. There are gaps in care even among those who have that routine care, and after hours is just one example of the types of gaps that people report. And this survey was, again, the Commonwealth Fund survey that looked at that compared responses among older people specifically, and this was in 2021, where Canada has among the lowest rates of individuals reporting that they have they find it easy to get medical care in the evenings or weekends. Compared to our peer countries, Canada doesn't do very well. And interestingly, also the survey of primary care physicians themselves showed that they were reporting to not offer weeknight appointments. And compared to other countries, the rates were quite low. Obviously, there's geographic variations in this in terms of even greater challenges in rural and remote areas. But what's interesting in this trend chart that even before the pandemic, these estimates were really similar to what they are now, or at least 2021 during the pandemic. So it's these are longstanding issues that haven't materially worsened during the pandemic, but this 2022 data are not available. Would be really interesting to see, and I'm sure things have gotten a little bit worse. I just want to spend a little bit of time, although not sufficient, to talk about inequalities in our society, including in health outcomes, are persistent and in many cases widening. And one of the challenges with really understanding the magnitude of inequalities is the lack of routine collection of sociodemographic data, the lack of routine reporting of such data. We do not routinely collect race-based data, and we rely, for instance, on census data to then link probabilistically with health data outcomes, but these are only available every 5 years. There's many issues with this in terms of both time lags, but also it can only really be done by Stats Canada. And this is one of their reports that was done by Statistics Canada in 2022. They reported these data from 2020, looking at COVID mortality specifically, and it was just striking but not surprising levels of inequality and who's impacted disproportionately by COVID. And you can see in the top chart, the rates of COVID mortality were significantly higher among Black Canadians than other populations in Canada. But when you looked at whether people were low income or not, it's predominantly Black Canadians living in lower income communities that had disproportionately higher rates of COVID-19 deaths. And these really reflect the structural inequities in access to housing and safe living and working conditions, which all contribute to exacerbating the risks and likelihood of COVID infection and its consequences. And just points to the need for the ability to be able to produce this type of data is really important and critical, and to understand both how, where are the priorities in terms of addressing them, but also to evaluate the different programs that we can implement in order to make a meaningful improvement. However, these challenges are not new. So many of these challenges were experienced long before, and we've known about them a long time, and they're long-standing, and they really do reflect, in part, our inability to change. And we know that spending, for example, on social care and social assistance has really stagnated over the past 2 decades. And though within health systems, we continue to invest and spend more and more, but no meaningful change to the way we're organizing healthcare. And when we look at universal health coverage, for example, there's been no change to what is within this basket of sort of deep universal coverage with no cost at the point of use, and access based on uniform terms and condition has been restricted to this narrow core of hospital and physician care. And that core of the health system has really been unchanged in the past half century. We've seen some movement toward expanding coverage in some areas where there's significant gaps. And there's been momentum toward universal pharmacare that had been really gaining over several years due to largely civil society movements, and led by some academics as well. But this has appeared to have stalled, and this, whether that's temporary or permanent, we don't know. But there's been some also movement around the dental coverage. I mean, this has been perhaps marginal, but the latest supply and confidence agreement between the federal NDP and Liberal governments included a very specific expansion for universal dental care, and however, it's still very targeted to lower income children living in lower income households. And the other gaps to coverage remain, such as with mental health and long-term care, where care is fragmented, inaccessible, in spite of what we see to be increasing investments. So we know these challenges are not new. They're going to require major change. So what should we prioritize? So arguably, maybe this is contentious, but I agree. I think we should be increasing investments, even though we're a top spender. Even though we've seen unprecedented increase in spending in recent years, this is not the time to withdraw and to face austerity measures. And on the one hand, the pandemic's not over, so those types of pandemic spending will need to continue. And then on the other hand, we're facing some acute workforce shortages as manifested by recent reports of even pediatric care being unable to provide routine and emergency care for the youngest, at least in Ontario, from what I've been reading recently, which is really terrifying, but going to basically underscoring the importance of urgent spending increase. We know that also the health ministers in Canada had a meeting last week, and there was some hope that there may be an agreement to increase the federal transfer, which it seemed the federal government was open to increasing the Canada Health transfer, but with some strings attached that were seen to be perhaps too restrictive for the governments to agree to. And this involved things like moving toward a health data system across the country. The types of data that could be used to see where the money is going and with what impacts. And so it's disappointing that agreement hadn't been made there, but there seems to be some progress, at least among health ministers working together to work on a national health workforce strategy. And we hope to see some more progress in that area. But we know that right now the nurses are leaving their jobs. There's higher vacancy rates than ever. So hopefully the public will help to rally and support the type of increased investment that we might see. However, these investments should not come without other changes. And on the financing side, we can think about ways to use the money differently. While in the short run, we might not be able to stop doing things, we know that delisting and removing services and programs that are offered without any evidence of value or improved health, we could remove those from coverage and work toward a process for doing so that could help to allow for increased expenditures, but also the way we pay for providers. We really have a lot of evidence from around the world on how to pay for hospitals. Canada is one of the few remaining countries to mostly fund hospitals using global budgets. How can we work toward more integrated models of funding that consider the care across the continuum when patients leave hospital walls, that type of bundled payment where there have been some trials in Ontario, for example, and shifting the doctors' payments away from fee-for-service. Again, we've seen some progress in this in primary care. We know a lot about how shifting financing models can help to move toward some progress in addressing these performance gaps. Another priority is not surprising since I mentioned data several times, but there's been a real lack in movement in improving our data information systems, and this could be a priority. And there's a lot of broader support for this now with the Pan-Canadian Health Data Strategy that's underway at federal level, that an expert advisory group had been struck to inform the development of the strategy and released several reports with their recommendations should be seriously considered. And I just include a rapid review cover. So the NAO has been involved in several rapid reviews in addition to those longer in-depth health system studies that look at specific pressing health policy issues. And we look to what other countries might be doing to address those issues and try and seek some recommendations or lessons for Canada. And this was a review that looked at what other federations are doing with regard to vaccine data and COVID vaccines specifically, and how do they enable the information sharing between subnational and national governments, and really show how Canada is a huge outlier in terms of the lack of data standardization and sharing that would enable the types of registries to be set up to allow for both the informing the ongoing rollout of vaccines and prioritizing populations who are most in need, but also the types of evaluations and real world analysis that can inform the future policy decisions. So this type of this was a really quick review that helped to inform the broader strategy, but there's a lot of rich information already compiled that we have the information to draw upon. So how do we move that to action? And then I included a few other data priorities here, where broadly increasing the interoperability of the data that we have, these, shifting away from a provider-centric model of data to more patient-centric. We have in Canada among the lowest rates of patients being able to access their own data among comparator countries as well. We also have many data gaps, for example, primary care, for example, in public health, long-term care, and in health human resources, which is critically important in order to inform the planning and the projections, given the challenges that we face in workforce right now. Another priority I didn't mention, I didn't go into detail on long-term care in the first part of my talk, but there's a huge amount of decades of research that has been done to outline the immense need and sort of building up the evidence of the challenges that need to be faced in long-term care, and focusing on supporting care workers, but also redesigning the way care is delivered. And I include some copies of reports here. One of them is the Royal Society of Canada report on COVID-19 and the future of long-term care, looking back at the key challenges facing long-term care and understanding how COVID-19 had such a devastating impact on residential long-term care and what the way forward is. That is one example. And I included another, it's the Campuses of Care report, written by some colleagues of mine, that really look to some of these more innovative approaches for long-term care, where there's a continuum of services of community support, housing options, long-term care, 24 hours of nursing support, types of care could be co-located or close to each other, as a way of supporting aging populations and sustaining health systems. And these recommendations are not new. This only includes, this slide shows only 4 reports, but there are hundreds that have been written to say, where do we need to go? And we know the evidence base is there, and the will and the effort to reform needs to be leveraged in part from the public, and our increased public interest in long-term care can be used to sort of shift this as a top priority in Canada. The last and fourth priority that I'm going to talk about in my short time here is around primary care. And Josep also spoke about the importance of primary care as not only as enabling health systems to respond effectively to the pandemic, but also for a long time we've known the importance of primary care and in improving health outcomes, reducing inequities, improving health system efficiency. And we have some experience with team-based primary care in Canada, but it's still very much at the margin and only available to very few Canadians. And if we were to be able to scale up these models, we could prioritize and better serve underserved communities. We could also be leveraging virtual care options where appropriate to support better access to primary care. And I just provided a few statistics that match a little bit what Josep was presenting, where the percentage of GPs or family physicians in Ontario jumped from 1% in February 2020 to 60% in BC. And in March 2021, and those same numbers went from 1 to 43% in Ontario. And so this is a potential tool that needs to be considered in terms of how to optimize and ensure its equitable use within primary care. And then we also are aware of the importance of supporting teams, supporting the primary care providers with the quality improvement information systems, administrative supports to make it possible for them to do their job, to love it, and to stay in their jobs. In primary care, last year was the number of family physicians who retired was twice that of the previous year. And we also know that fewer medical residents are choosing family medicine. So there's this challenge of maintaining the core healthcare workforce in primary care, and task shifting and optimizing scopes of practice will be among those strategies. I also mentioned here just how we have a lot of contracts in place in Canada too that are supporting these team-based models, and we could move to strengthen the use of contracts to try and shift from more of a passive purchaser or payer of primary care to something more strategic, to have a few more requirements for the things that we're really missing, like the after hours care, like following patients and ensuring integration with other actors. So I'll just close with a couple points, and then I look forward to a discussion and hearing your questions. But I think, the types of reforms needed if we were going to address any of these top priorities, we're going to require a lot of support from the public. And we had really high levels of trust in Canada relative to other countries, both in government and in health systems going into COVID. And we're seeing some signs of that trust declining. We also see democratic participation, at least in some recent elections, very low. These are concerning, and we need to think about how the types of reforms that we're going to be needing will also depend on strengthening trust and participation, because we know that the professions themselves, the nurses and the physicians, need to be involved in implementing, but also designing and leading reforms. But we also need the public support and participation in calling for and holding governments to account, and to ensuring that the reforms are meeting the local needs at the community level. And then in some, the inequities that I mentioned really briefly, we know that this is will never meaningfully improve until we act on social and structural determinants of health, and that goes beyond what the health system can do specifically, but it speaks a lot to the intersectoral and the sort of health and all policies that we can do in partnership with other sectors. So I'll leave it at that, and I will stop sharing the slides and look forward to hearing from you.
Thanks so much, Sarah. Excellent summary, I think, of a lot of the things we've been talking about in Canada for the last several years, but really brought sharply into focus in the last few years. And there's some great comments in the chat that I'll get to, but I'm going to take chair's prerogative and pose a question or a series of comments and then a question to both of you, just to try to bring some of it together. And it really feeds off your concluding remarks, Sarah, and hearkening back to Joseph's sort of notion of health in all policies, the notion of health as the sort of prime directive as opposed to healthcare. In other words, should we be investing in the achievement of health versus investing in healthcare? And just to pose an example, we know that there are many urban areas in Canada, and I'm thinking of Hamilton in particular, where adjacent neighborhoods defined by different postal codes have life expectancy that's fully 10 years different, even though they have access to exactly the same healthcare system, at least in principle. And just focusing on the importance of health to Canadians. And Ryan Miley has said this, and I'm stealing from him, but we often say, oh, you're having a baby, is it a boy or a girl? And we say, oh, it doesn't really matter as long as the baby's healthy. When we toast each other, we toast to our health. And when something bad happens in our lives, people who console us say, well, at least you have your health. This notion of health as the thing we want to achieve. So I just wondered if you might reflect a little bit, especially given the sobering stats you gave us, Sarah, on the amount of money we're spending as a percentage of GDP, the results we're getting for it. But then we have innovators in Canada, people like Gary Block, who talk about prescribing money, the notion that the best thing I can do for some of my patients' health is to put money in their pocket. It's kind of a stark way to kind of pose the issue. But just some further reflections on the notion of investments in health versus in the healthcare system en route to better outcomes. And maybe Sarah, since you're hot off your last presentation, I'll invite you to comment first.
Sure, thank you for that great question and important. It's a puzzle. It's a complex issue that we've been grappling with for my whole career, and so I don't have an answer, but I do have maybe a reframing on the role of health systems, and we could remember that the health system itself, in terms of how it's financed and how it's delivered, could be a major factor in reducing income inequality. And so perhaps even more important than primary care providers prescribing income, we could ensure that the health system, it continues to be financed in a progressive way, that we increase progressive taxes to fund health systems. And we ensure that the people who are most in need, especially in, those have higher health needs, tend to be in lower socioeconomic groupings. And so both the net effect of the finance and then the utilization is actually significant in reducing income inequality. So that in itself is a determinant of health that the health system can contribute to by its design. And so at the least, the health system should not exacerbate inequities that we know are broader throughout our society. So, the way that the Canada Health Act talks about uniformity in access and uniform terms and conditions, I think that's been a major contributor to the ability of the health system to at least not make health and socioeconomic inequalities even worse. But I'm curious to hear Joseph's thought as well. I'm happy to
Yeah, go ahead, Joseph. Just reflections on that. And I think, I don't want to put words in your mouth, but I think you were sort of alluding that some measure of health, like a health index, could be just as important to the well-being of a nation as its GDP. Perhaps.
Yes. Well, it's something very close to my heart, Chris, actually. When I was a GP, as it happens, I was in one of these pilot areas where the new generation of family practitioners, and we were in the most deprived area of that particular city. Around 40% of my patients were unemployed, and I used to use long-term sick benefits as a way to compensate for the lack of social services and unemployment benefits. Probably I shouldn't be saying that. I could still be sued by the system by using, but that was the best thing I could do for that population because they were close to starving, and I would put them in in healthcare benefits as the only way to chronic sickness. So that I understand that. And actually my transition to being a GP to work in public health in the first instance was my impotence, realizing that those determinants were there. I do think there is Sarah said that beautifully well. I mean, it's all this concept about financial protection and how, user charges can lead to poverty. And there is all this work. Actually, the Canadians have been leading the debate. I don't know how much you implemented for many years about the health in all policies, actually, in the sense that, health resides in other areas. And we have plenty. One of the most interesting areas now is the co-benefits from the environment. There's very health co-benefits from investing in the environment. It's quite an attractive, actually, approach to it. What I was referring earlier is about the economy of well-being. So there is a movement now, I explained it too quickly, started by the Finnish presidency of the European Union a while ago. I was part of that movement. And in countries like Finland, of course, Netherlands or New Zealand, where they're trying to allocate resources within government based on measures of well-being. What are the key elements? Is it child health? Is it gender equality? What are the key elements in the priorities within a country that increase the well-being of that society, and try to allocate resources according to that, within which health in itself is a very important component, as well as a medium for reducing poverty, as a medium for gender equality, and so on. So I think that's very much the way forward. The way that the Scandinavians, Finland, put that forward is saying well-being, it's an indicator of the progressivity of the wealth of societies, as it were, number one, but there's a positive loop. Well-being societies are more productive and happier societies. So in some ways, I suppose I defend their Scandinavian model by which you actually can invest on your population in social welfare, in employment training programs. And at the same time, that has a positive impact on the economy. And actually, as you know, in the happiness indicators, the Nordics are the ones doing the best. And they don't have necessarily that many natural resources, with the exception of the Norwegians and the gas and the oil, of course. So I suppose this concept of the economy of well-being tries also to underline the particular model of society.
Thank you, Joseph. We'll just move to some of the Q&A in the chat, and we can maybe do some rapid fire. First question from Elizabeth is around cultural sensitivity and Indigenous evaluation of healthcare practices. The way that I've interpreted that is, when we talk about evidence-informed healthcare policy, how do we bring some of these other forms of knowledge to the fore? So, we, those of us who have been traditionally trained in, statistical analysis and, this sort of thing, I think on all of our personal learning journeys, those of us who have been privileged in society are learning much more that there's lots of other kinds of knowledge out there. And how do we bring that to the evidence-informed paradigm, particularly referring to the Indigenous community and what their scholars and knowledge keepers are bringing to the debate? Sarah, you want to kick that one off?
Sure. And I think it's often helpful for me to go back and look at the recommendations of the Truth and Reconciliation Commission, because this was a huge amount of work and of learning about the truth in Canadian history of experiences of Indigenous peoples, especially in the residential schools, and how these have informed specific recommendations within the health sector and others. So this, I think we need to track, we need to keep trying to move and follow these well-informed recommendations, and that includes the types of learning that you spoke to, Chris, in terms of our own learning journeys, but to support broader training and learning about the truth about our society and ongoing experiences of racism and anti-Indigenous racism specifically. And so that's one thing. Follow the recommendations of the TRC, embed better education systems, including for our children, but also healthcare providers. But also community engagement goes to all, that point I ended with really speaks to the importance of learning from communities and patients and families' experiences. And there are ways of, learning from existing models that work. So community governed healthcare, so community health centers, for example, and Indigenous led community health centers really provided a way of operationalizing this. So how we have examples of how this works, and we need to pay more attention to what is currently being done in those models and scale those up.
Thanks, Sarah. And go ahead, Joseph.
Yeah, no, I totally agree, needless to say. There's a complementary element about which we learned a lot during the COVID crisis and the vaccine. The anti-vaxxers, well, they are organized movements, but also they took place in particular cultural, religious, Indigenous, ethnic minorities groups, that actually the response against vaccination had to do much more a general response to society, to authority, to government, rather than on the vaccine itself. And some of the very effective strategies has been working with the leaders of these communities, trying to understand where they're coming from, how they perceive all that, and tailor those messages, involve them in making change. So my 2 points, one was about infodemics and trying to monitor the views and perceptions of society, of different groups, and particularly these minority groups sometimes that have more vulnerable or have been mistreated, number one. And number two, finding ways to work with them. It seems to me, was talking about civil society and civil society understanding as well, cultural groups. It's been key actually to bring these groups on board. Which are groups, Chris? Which are groups? When you look at the impact of COVID, the financial crisis, work we did with Sarah many years ago as well, you realize that the biggest brunt, the biggest impact is on those groups. The overall averages, sometimes they're not affected, but you have to look at these groups, and this is where you get the highest morbidity and mortality. So positive discrimination in the sense of putting resources in these groups is not just equitable, but it's value for money as well in terms of the overall health of our populations.
Thank you very much. Next couple of questions, I think, are, I would say, about the readiness of society to embark on transformational change. And I know transformational is an overused word for sure, but the first question is around, are Canadians basically ready to, recognize their underperforming system and ready to sort of take on some of the fundamental change that's required, that has to sort of span political cycles. And then Kevin asks, are we ready now, after going through this, to tackle some big things like Biden's moonshot for cancer, or are we just going to kind of continue to muddle through incrementally? My own observation has been that we said at the very beginning of the pandemic, let's not waste all this disruption. Let's make sure we capture all of this energy and restlessness and emerge on the other side, the build back better, Joseph, that you've been talking about. But there's definitely a fatigue. There's very much a let's retreat to the psychological safety of the way things used to be, the status quo. That seems to be kind of entering. So I think both questions are asking, how do we sort of keep the public ready for this kind of change management, the risk taking that's going to be required to do some of these heavy lifts? Joseph, let me go to you first.
Perhaps I should take much more I'll leave the Canadian question to Sarah, and perhaps I can take this idea of listen, Chris, I'm still an optimist. And I think I'm the last optimist left in the face of Earth. I keep going to conferences and I don't get much of a positive feedback. But I've seen some positive moves. The pandemic treaty, the role of the G20 now possibly on funds on health, sort of One Health approaches. In this part of the world, with the EU countries that, as I said earlier, very quickly, they're very reluctant to pull sovereignty, now ready to pull sovereignty, ready to play a global health role. Now the EU is passing a strategy on global health, trying to be much more involved with development monies and supports and so on, and realizing that health is indeed beyond the health system and has to do with trade, has to do with development, has to do with many, many other areas, the industrial policy, markets, and so on. So I see for the first time a real appetite, not perhaps by wish, but by default, in actually working together and finding common solutions. In the area of research, I think is extremely important. We have to pool resources in common challenges, Alzheimer, cancer, and others. Of course, the issue is the commercial interest, and illicit in many ways, the pharmaceutical industry interest and so on. But there are ways. Right now, we're working in many ways to procure, for instance, innovation and pharmaceuticals here in the European Union, ensuring that there are enough incentives for the industry, risk sharing, and at the same time pooling resources to benefit to the access of these new innovations. So I think we are in the right direction, and still I would like to see national budgets of research being pulled together and understood as a public good. We're far from there, but I think all these shocks that are getting close to us, the environment, another financial crisis probably that is approaching us, will lead member states at that level to actually work closer together and find common solutions.
Thank you, sir. And Sarah, do we have the ability to harness restlessness in the system for the acceleration of the healthcare transformation agenda, or are people just tired out?
Yeah, I'm not as optimistic as Joseph, to be honest, partly because, there was a lot of hope going into the intergovernmental meeting last week in Canada with, we know that the governments have been working at, more closely together than ever before, with intense levels of collaboration and frequency of meetings that we've never seen. And yet the negotiation for an increased federal transfer to governments, which was seen to be, needed at least in the short run to ensure that when our kids get sick, they can get care they need in an emergency room, for example. And those broke down right away. So that's disappointing. And yet perhaps that type of that sort of paralysis that we face in Canada might galvanize some public attention, because we know this is facing people's lives so harshly right now. So maybe that is yet another crisis that will motivate. And then perhaps what gives me hope is, and again, Giuseppe spoke to this, the kind of community mobilization and efforts to empower and to partner with community ambassadors and advocates and members to collectively work on the pandemic responses, really provide a bit of a map, a plan for how we can move forward in health systems broadly. So we've seen that in Canada as well. A huge amount of investment and activity at the community level that was led by faith leaders, by community leaders in partnership with acute care and public health leaders. That I'm working with some colleagues on a project that seeks to understand how these worked, what worked well and what didn't, to really try and share some of the learnings from that could be brought forward as we enter this sort of recovery stage of the pandemic.
Thanks, Sarah. And I think the next one may be for you too. And again, I'll paraphrase and add some color commentary. But yeah, I think you one of your 5 points was really strengthening primary care. In Ontario, we know that 1.8 million people are without a primary care provider. An additional 1.9 million people have a primary care provider over the age of 65. So in addition to those unattached patients, there's certainly a widespread kind of perception that maybe healthcare workers are working less, and that a lot of people are coming to emerge as their kind of first stopping point. Before I invite you to comment, I would just add that Canadians coming to emerge has been a thing for a long time. I think we know that Canadians use the emergency department more per capita than any other OECD countries. So we have this go to emerge culture, but in the current context, there's a real worry that that's contributing to the congestion. So wondered specifically to the question that's posed, do we have a problem with access to primary care?
It's a huge problem, and I can't say that there's any one particular driver. I know that there's huge variation in the time that family physicians work, and many part-time workers, which is critical to their own well-being and health and the way they want to live their lives. And so I think there's, it's really hard to know what single driver is leading to this access problem, but this has been going on a long time, and I think the idea of a team is just so critical. It's like a no-brainer, because my family physician is on long-term sick leave, and so where does that leave me? I think many individuals are facing this problem in Canada, that there's nowhere else to go, and so the emergency department is the go-to. However, we know that teams can support each other and provide the quality of life for the workers, and deal with the increasing retirement rates, for example. And nurses prescribing, as Joseph mentioned, nurse practitioners joining teams and working across all the allied professions is a promising model. And we've been trying to move toward this, and we have many different variations of it. But I think that's really helpful to allow both the providers to work in the type of practice that they want and with the flexibility that they want, but to be supported to provide and look after their patients both during the office hours and beyond.
Can I echo that, Chris? It's yes. Something we're facing elsewhere. One of the countries I was the fondest of in terms of primary healthcare is the Netherlands, and even the Netherlands is facing this issue of primary healthcare burnout. And the other day, running a session, I had the representative of the young professionals, the young medical doctors, and he was saying, listen, man, listen, Joseph, we just cannot do this continuity of care. You cannot ask to be in primary healthcare ward 24 hours a day. We understand it's ideal. We have families. We want to enjoy our lives. We prefer to work 8 hours a day. We don't want to take responsibility of our own practice and take all these responsibilities. And we have to listen to that, because we are not getting vocations into primary healthcare. It's not about money, it's not flexibility. There's a question over here about rural areas. There are ways to bring people to rural areas, but there are ways to bring rural areas that, in a way that they are contacted to a main center in a city where these people can be rotated, where there are facilities for their families. All these elements we keep forgetting, and we talk about money, and that's not enough. So the flexibility of the working conditions, the acceptance that this is a reality is very important for our policymakers now. indeed.
Well, thanks, Joseph. And I just have about a minute or so before we turn things back to Carolyn to close. And I just wanted to reflect on one other question that is basically saying, how do we know that the pandemic is over? I think what I would say to that is that we're now kind of transitioning into the impact of the pandemic, or what some have called the pandemic syndrome. All of the things that have fallen out of the pandemic. The current RSV and influenza wave in Ontario, for example, is a consequence of the pandemic, but it's got nothing to do with COVID-19 other than the fact that the public health measures we've taken over the past 2 or 3 years have probably, inadvertently led to a lot of disease kind of happening all at once. So it's a good question, because I think, there's a huge desire by the public to have this kind of binary, we're now going to move on, like the war is over, the pandemic is over. But we can't lose sight of the fact that the impact, and maybe on the more optimistic side, the opportunities for learning and transformation are still there. So I'm sorry we didn't get to all of the questions. A lot of great questions there about wait times, access to care, about trust in our institutions, I think, that are great to take back for reflection. But Carolyn, let me hand it back to you for closing comments.
Well, thank you so much, Chris. Thanks for that very interesting concluding comment as well. On behalf of everyone watching, let me thank our moderator, Chris, our speakers, Joseph and Sarah, for a really engaging and thought-provoking discussion of these issues that are of such pressing concern in Canada and elsewhere, and of such importance for what can be done in social policy more generally. This has been just the sort of deeply informed, evidence-based, policy-relevant work that we seek at the International Institute to bring to the audience. So many thanks to all three of you. 2 days from now, on Wednesday, November 16th, we will have the 7th and 8th of our series of panels, the only time we will have 2 panels in one day. From 12 to 1 p.m., we have a panel on disability, in which the speakers will be Suzanne Bruyere, Professor of Disability Studies at Cornell University, and Michael Prince, a Professor of Social Policy at the University of Victoria. And the session will be moderated by Sherry Torsman, the former Vice President of the Caledon Institute on Social Policy, and well known undoubtedly to many on this call. And then that panel will be followed from 1 to 2 p.m. by a panel on mental health, at which we will hear from Howard Goldman, Professor of Psychiatry at the University of Maryland School of Medicine, and Kwame McKenzie, Professor of Psychiatry at the University of Toronto and CEO of the Wellesley Institute. And that panel will be moderated by Tatum Wilson, who is the CEO of Children's Mental Health Ontario. You can register online for those panels and for the final session of the series on Friday of this week on the public and political landscape for social policy. So to register, just go to the conference site on the Munk School of Global Affairs and Public Policy's website. And before closing, I would like to thank Employment and Social Development Canada and Immigration, Refugees and Citizenship Canada for their generous support, which has allowed us to bring leading international and Canadian experts to this public forum. Thanks to all of you for joining us. Goodbye for now, and enjoy the rest of your day.